Okay, so today we're going to review insulin resistance, which is a super important topic. This is basically the underlying disease process for many chronic diseases that we develop, the most common of which people know is type 2 diabetes. And then actually one that's becoming more of an epidemic that's sort of under maybe appreciated is fatty liver disease, metabolic associated fatty liver disease, which can go all the way up to liver cirrhosis, scarring, and liver failure. So again, really important disease, drives cancer, maybe drives cardiovascular disease, really drives a lot of our important diseases. So just want everyone to have a good idea of some of the important aspects and just what this is. So we'll start with insulin's normal actions. So insulin basically is a hormone in our body that's made to basically give signals around nutrition. And so it does respond in response to nutrients, primarily that blood glucose, which is usually driven up very strongly by things like carbohydrates or sugars. We can talk a little bit about what a carbohydrate is. Basically, it's any sort of chain of sugars that practically is foods like what we call kind of starches, potato, rice, flour, but again, our good, quote unquote, better carbohydrates are things like our vegetables also are carbohydrates. So broccoli, cauliflower, all these things are also carbohydrates. And again, some of these just have different responses in our body with insulin. So it is a growth and building hormone. So it pushes basically this glucose that's ultimately sort of digested in our gut into our bloodstream. It pushes that into our cells. And so then inside those cells, we can actually make energy out of this. So glucose isn't necessarily energy. It's sort of a building block for energy. And one of the other things that's important in this concept is, again, it cannot get into the cell from the blood without the signal of insulin. So it's really a pretty necessary component of our body to regulate our blood sugar, which generally is a very tightly controlled number in, again, most metabolically healthy people. Ideally, that's sort of the definition of metabolically healthy, is that you do keep that blood glucose under pretty tight control. So we do that largely, but with this hormone insulin. Couple other things that we may not know about insulin, and again, liver and muscle are the main two organs that are doing a lot of that processing and responding to insulin's actions here. So it also increases the fat content of fat cells. So we have adipose tissue or fat cells that are intended to be an energy well or storage for us. We have two main types of fat in our body. One is visceral fat and one is subcutaneous fat. And most studies would really support that a lot of visceral fat is really what we want to go against. So that's sort of around our organs, around the abdomen kind of area, where subcutaneous is, again, as you were kind of think, beneath the skin, so kind of in our limbs and, a little bit more in our periphery, so on the outside, away from our core, whereas visceral fat's more closer to our core. And again, insulin is going to increase fat storage everywhere. However, it does seem to maybe selectively increase that visceral fat. One of the other things it does do, which is, can be used in beneficial ways, is increase protein uptake and protein synthesis. So it basically is telling your body, hey, there's energy here, so let's do something with that energy. And so again, this has been used to the advantage of folks like bodybuilders and other power lifters and things of that nature to really amplify their growth. So commonly, after a very good resistance workout, a lot of people will maybe consume a large amount of carbohydrate to get this insulin response to favor some of this. So again, it's not all necessarily bad or good. Insulin just has certain actions in the body and responds to certain things. And hopefully we can kind of just get to the concepts of this is what's happening, and then we can make maybe better decisions around what we want to do. So insulin within the body, again, this is just, I like pictures, so I try to include some pictures in these talks. So again, we eat something that has some, nutrients that will turn into blood glucose. Then we get an insulin response. And actually, that response will usually start a little bit right before we eat, just from the smells, from the sights of food. So this is a very, unconscious and innate process that's happening in our body. And then certainly as that food is ingested, we have all sorts of nutrient sensing kind of pathways in our gut that really amplify that response based on exactly what we've eaten. Insulin is produced in the pancreas. I don't know if I mentioned that, but the pancreas is kind of, again, that main organ that really releases this hormone. So again, just pictorially, we're talking about kind of uptake of glucose in the muscle, as well as, again, getting some fat into those fat cells, and then the liver, which actually does a number of different things based on insulin's actions. So the liver will actually make less sugar itself, burn less fat itself, and that's what gluconeogenesis and lipolysis mean. Apoptosis means that sort of just a programmed cell death, so cell turnover, which again can be actually for a good reason, kind of older cells that maybe need to be recycled, which is autophagy. So again, some of these down regulations may not be a good thing, but it does, again, do these things that makes more protein. It does put a little bit more fat out into the circulation. It also makes sort of liver fat in response to insulin, so it will turn sugar into fat in order to store it long term. And again, the reason for that is that glucose is really intended to be sort of a short burst of energy, and fat is really our most efficient form of energy. So the body really, if you think about it from an evolutionary perspective, we really want to be able to turn things into fat so that we can turn food now into energy later, rather than be forced to sort of burn that right now, right? So if we're always in a glucose burning kind of mode, then we would constantly need to be eating, and that would be very inefficient, let's say, for survival long term of the species. So I think that's an important kind of way to think about this, so that we're not thinking, hey, again, why? I think that's an important question. I think this is the best answer I have for folks. Just a quick kind of pictorial diagram of what insulin is actually doing on a cellular level. So like I said, it's a hormone. What does that mean? Basically, it means it's a chain of amino, it's a protein kind of structure in the body, which is attaching to receptors elsewhere from the organ that it's produced. So again, insulin's produced by the pancreas, and it's having actions on what we're going to focus on today is mostly liver and muscle cells. So it attaches to that receptor. The cell has basically a little glove that can catch that ball, and it recognizes they're kind of a perfect fit. And then a chain of things will happen, which will basically allow sugar, now glucose from the blood, to enter that cell and be processed. Okay, so then what is insulin resistance? So basically, when this process is, it's a necessary process for life. We've discovered basically over, multiple studies and tests that as we form this thing we're calling insulin resistance, basically what that means is that for the same amount of sugar that a person is given, then their pancreas is needing to produce more and more units of insulin in order to push this sugar back into the cells and keep their blood sugar normal. So through some intricate testing, basically this was shown that yes, in sort of quote unquote metabolically healthy kind of individuals, there's a certain pattern. And then sort of as we get more and more insulin resistant all the way up to type 2 diabetes, that there's sort of a spectrum of how high insulin you need to sort of accommodate, let's say, sort of an even amount of, so 100 grams, let's say, for example, of pure glucose. So that's basically what is the kind of scientific definition of this. And basically, what does that mean practically? Muscle and liver basically is not responding to insulin in the same way. And through, again, some really intricate research, Gary Schulman, who I have gotten a lot of this from through Peter Attia's website, that he has done a lot of this research to show that basically the intracellular accumulation of a specific type of fat in the processing of glucose. Again, the body wants to try to turn this into long-term storage, so it's trying to turn that extra glucose into fat. And if there's just not enough, or actually first it wants to actually make glycogen, which is the main storage form of glucose. And so when glycogen stores are basically saturated, because each cell can only take a small amount of glycogen, then it starts to make this fat. And so that is basically what we think is the root cause of this insulin resistance. So basically the body is saying, the muscle and liver, we're full of glycogen, we can't make any more glycogen. We need to turn this into a sort of long-term storage molecule, which I'm calling just generically a fat. It's a specific type of triglyceride, and that impairs insulin's actual signal on that cell. So then the body responds, the pancreas responds just by giving more insulin, basically to try to overcome that signal. So that's on a very granular cellular level, what is happening with insulin resistance. Again, this gone totally haywire once blood sugar starts to rise, then we start to call that prediabetes or type 2 diabetes. But this process actually probably starts in most people up to a decade or so before they have that blood sugar rise. So the reason that type 2 diabetes is more well known is historically, right, this was not detectable until sugar was high. We just didn't have the technology. We didn't have the intricate knowledge that we have now with the body. And what we saw is that, okay, people's sugars are so high that they're literally peeing out sugar. And now we can, I mean, literally doctors would taste and smell the urine. And that's how diabetes was essentially discovered, right? But now we know much more about the body, much more intricate ways to test this stuff. And we definitely know that insulin resistance starts much before we need to be peeing out sugar and detecting it that way. So again, this exists on a spectrum, and the point of telling that story is that this starts much before we have those overt signs of, okay, increased thirst, blood sugar is very high. And again, this is in insulin resistance and type 2 diabetes. I will talk a little bit about the difference between that and type 1 diabetes. With this type of thing, insulin resistance, what I'm talking about here, I do believe that this is reversible in most cases with diet and exercise. Again, there are some genetic factors, there are some diseases that actually make this sort of much more likely and can make it very difficult to, manage this and may need the addition of medications or other things like that. So there's a variety of genetic conditions that I won't necessarily go into here. We're trying to focus on what 90 or plus % of people are dealing with, which is really this reversible form of insulin resistance. It is more than just maybe eating too many carbs. So again, we do want to have that full life kind of approach and looking at all angles of our life. So we notice that even in the short term, poor sleep, so a couple nights of poor sleep can actually induce insulin resistance in people acutely, even when they don't have insulin resistance overall. So that's a very interesting kind of thing. And then you can imagine if they already have resistance, what it maybe does to them. And then chronic stress. Again, this is kind of chronic unmitigated stress. I always remind people that stress is an absolutely necessary feature of life if you want to grow, heal, get over a virus, an infection, or just even in a mental aspect, have growth and learn. We have to sort of put ourselves into new experience, which you could sort of describe as stress. Again, acute stress is not what we're talking about here, but that chronic stress where maybe, again, it's affecting that sleep or it's affecting the way you interact with other people, your relationships in your life, or many other things that stress can do. So let's see this last thing. So why does insulin resistance occur? Again, so that last bullet point is basically just addressing that it's thought that this would allow blood sugar to stay high. So one of the things we also see is that in periods of very extreme starvation, we will actually induce insulin resistance. And so it's thought that in those extreme cases, this is actually protective to keep blood sugar high so that the brain has access to glucose. And again, as sort of Andrew Huberman says, I wasn't consulted in the design phase, but again, these are our best theories of why sometimes these things are happening. So disease associations. So great. So here we're talking about just why is this important for all of us? So it's the likely causative in many of these diseases. So as I referred to, fatty liver disease, which can escalate all the way up to liver failure. So let's see, all the way up to liver failure. And then we have, of course, type 2 diabetes, which is the most well-known of these. But again, we're starting to see a lot more and maybe even causative links with things like Alzheimer's dementia, maybe perhaps other forms of dementia with insulin resistance. And again, this may be associated with lower levels of insulin resistance, which don't meet the thresholds for type 2 diabetes. So cardiovascular disease, again, that's also believed to be at lower levels of insulin resistance. So let's say with pre-diabetics, right, we still see this elevation in cardiovascular disease. And again, some certain cancers seem to be. So remember, I said insulin is actually a growth hormone, of many kinds to many tissues, right? It's intended to say, hey, energy is here, take up this energy. And so, cancer is kind of this overall as a disease is basically overgrowing cell that's gone haywire and just growing uncontrollably. And so often some of our natural hormones, which are intended to grow our normal tissues, certainly also grow cancers. And so insulin is not unique in that way, but certainly does drive cancer. Metabolic syndrome, right? So this is kind of the five, or there's different definitions of metabolic syndrome, but the pattern we see in folks with insulin resistance and something we would then classify as metabolic syndrome is high triglycerides, low HDL, that increased blood pressure, increased waist circumference, and then increased measurements of insulin resistance. So what is double diabetes? So this is where I sort of address the type 1, type 2 type thing. So type 1, again, the reason both of these are named diabetes is because they were discovered because of high blood sugar. So that being the case, they both got named diabetes. However, type 1 is actually where you cannot make insulin anymore. And that can be either because you've been a type 2 for so long that the pancreas is now burned out, or maybe more commonly known as sort of childhood diabetes. This is more autoimmune disease. Again, we don't fully know all of the causes of why, but basically children's, a lot of times pancreas will stop producing insulin, and a lot of times it's antibodies against those cells that make insulin, or insulin receptors or other things like that in the body. So there seems to be this autoimmune component, but again, ultimately what causes our immune system to do that and why it presents at 8 or 9 as opposed to from birth, we really don't fully understand. So again, just kind of illustrating that these actually have a very different root cause and sort of end in the same thing with high blood sugar. Type 1 patients, what many people might not realize, they're not immune from insulin resistance. So if they are sort of seeing that their insulin doses are just escalating, right, that's sort of a very good sign that they are developing insulin resistance. And that's what that double diabetes really is that type 1 who is now also insulin resistant and maybe also has, quote, type 2 diabetes as well. So again, insulin as an intervention, in general, is really not shown to, improve people's lifespan independent of sort of what it does to blood sugar. So that's sort of an interesting piece of data. Again, that's mostly in type 2 diabetics I'm talking about here. So adding insulin in that insulin resistant group is something that in general doesn't seem to really have, again, I would argue that sometimes it's necessary, of course, to keep blood sugar in control. But what I'm trying to say is that maybe not getting there is really a much better goal. So this is all great. What is, we've talked a lot about why it's important. So how do I know if I have insulin resistance, right? So there's certain kind of easier labs to do and some more intricate labs to do if we really want to get down to the bottom of some of this. So the basic things that I think that everyone in my office gets here are things like fasting glucose, fasting insulin level, basic lipid panel. We always look at liver enzymes, and then sort of after that, and the A1C there at the end. The 2-hour, what's called an oral glucose tolerance test there, OGT, is basically a test that requires a little bit more doing. So that is going into the lab, getting a fasting glucose done, then drinking 75 grams of glucose and getting basically 2 more blood draws on timed 1 hour and 2-hour marks. So that is kind of the gold standard. If you really want to know, if you feel like maybe this is not an accurate diagnosis, then I would say that is the test that we definitely want to do to really prove this one way or another. And if you really want to get intricate, you really want to do that with insulin levels, not just glucose levels as well. And again, I think that is very possible, but it is probably about 2 to 3 hours of your day. And again, the glucose drink itself is, I've been told, very nasty. So anyway, so what are some other kind of things that might be risk factors, right, in our lifestyle? So looking at how much of our, what's our total calorie intake? What is this breakup of those calories as far as macros go? And again, we can put out some literature more specific to the differences between carbohydrates, proteins, and fats. But for here, I'll just kind of mention that generic kind of macro term and specific types of carbohydrates. We're talking about here. So this is where I was saying broccoli has carbohydrates, potatoes are carbohydrates. So again, having some of those quote simple sugars. So fructose, high fructose content, high glucose content, things like this, as opposed to these long chains of sugars or what we call fiber. Fiber is a specific type of carbohydrate that really does not seem to impact blood sugar. Many fibers are not even absorbed and really act as food for our gut microbiome. And so that's another very important aspect of eating high fiber foods, which technically is a carbohydrate as well. GI index, always, it's GI stands for glycemic index. So that's kind of, and then there's glycemic load, right? Those are just measurements on food. So just looking at the GI index or glycemic load in, numbers of your foods. Other things that you may see is increased waist circumference. This seems to, and visceral fat, seems to sort of be a vicious cycle. They both kind of encourage each other. So if you have one, you're more likely to have the other, sort of thing. Physical activity, and this is mostly inactivity, sort of as a risk factor, and then certainly muscularity and body composition are important things to think about with insulin resistance, especially reversing it, increasing that muscular activity or muscularity as a part of body composition, primarily through things like resistance exercise, and then physical activity really of any kind, and specifically we'll get into some of that as well. So something we're trying to maybe bring in office here is a point-of-care ultrasound that might be able to look at some liver scar and liver fibrosis. But nowadays we can really get some testing, and liver ultrasound seems to be the most sensitive thing for looking at the liver to see if we already have fat deposits or maybe there's some signs of scarring even on the liver. The labs are okay, but it seems like ultrasounds are definitely more telling. Just a quick note on sort of, maybe what a lot of people have been told, either at other offices or by other providers, or, maybe a lot of, just again, in the community, versus an opinion that something that I think is maybe more proactive, right? So a lot of people just advocate for waiting for that A1C change. You're okay until your A1C is 6.5 or 7 or whatever it may be. And I think, again, this is a very personalized approach. And if the patient kind of knows all of everything we just talked about and really wants to wait for that A1C to change before they do anything, then I'm not going to be upset or tell them otherwise. But I really feel we should give people the opportunity to intervene much before that A1C change, knowing now how dangerous this can be even in early stages, and how long it takes to maybe get to that A1C change, right? So if we're talking about a decade of dysfunction before that, then I really feel like we should be giving people an opportunity anywhere there along the road. What we're seeing is that this is becoming the leading cause of liver failure. So actually, our transplant list, is no longer topped by people that, previously might have been alcoholics that have destroyed their liver, or hepatitis patients who, had viruses that destroyed their liver. Now, actually, liver fat from basically our metabolism is the leading cause of liver failure, or becoming quickly the leading cause of liver failure, which is just really eye-opening, I think. And again, just to reiterate, it raises, kind of our four horsemen approach, or most common chronic diseases and causes of disability, right? Cardiovascular disease, dementia, cancer, again, seems to have associations with these things before that A1C change. So again, hopefully taking action early, I think, is really, hopefully I'm convincing you that taking action early is something that's worth your time. Again, we don't even test, right, in traditional settings outside of pregnancy. I don't think anyone's ever done a glucose tolerance test. So, I very rarely have other people, come in with insulin levels outside of maybe having they're trying to see whether they're type 1 or type 2, or some specific kind of instances where they already have diabetes. I don't think quote unquote healthy folks are getting insulin levels or glucose tolerance testing in most settings. And again, this is relatively cheap testing in my clinic as a DPC member. So, so again, once medications are needed, just like to reiterate that likely a long time has passed, and a lot of opportunities may have been lost along the way there. So, okay, so what do we do here? So, I'm going to talk about this again kind of in broad strokes, and we hope to have, again, more material that really addresses very granular, specific kind of things in these categories. But I do want to just go over some large concepts today. So reduce intake, right? So I realize that that's really greatly simplifying it, but again, we're just trying to get to the core of this on a very great, specific, simple level, so that everybody can apply this in their own way. So yeah, you do want to really focus on the simple carbohydrates, but really what I'm saying here is that if you ate just pure sugar all the time, and reduced your overall calories enough, you probably would still improve this. But I think you would feel so terrible and hungry that really wouldn't be a viable strategy or sustainable strategy, right? So reducing intake, even if it is purely from carbohydrate, I do think many studies support that would actually help too. But again, I think that would be increasingly hard for folks to maintain. So I think a more approachable or more sustainable approach would be really to increase that protein content of your diet, increase that complex carbohydrates. So that looks like our greens, veggies, kind of high fiber options, beans, nuts, seeds, things of that nature, legumes, as opposed to some of our more quote starchy carbohydrates. Again, this is fructose special, so high fructose corn syrup's really gotten a bad rap. And again, we've all maybe heard about this word fructose. And again, I think a lot of studies support that, again, if you ate purely fructose, maybe there's some special part of that in the metabolic switch in the liver, but if you're really under caloried and it's still over, mostly from fructose, it seems like you would still really probably not develop this, right, or still be able to reverse this. And again, the point there is that most people are going to feel so dissatisfied, hungry, uneven energy, that is not, again, a great strategy, I think. And that's really the more important reason of why to avoid fructose, is for the way it sort of interferes with our hunger signals, and again, may have sort of a special role in the liver. So increase output, right? So burn more energy off those muscles. we said that muscles were saturated with energy as sort of one of the root causes of this resistance. Why, or were they not responding to that insulin? So we really want to focus on this. Zone 2 cardio seems to, again, be a sort of special. So this is this moderate level of exercise. Again, we do have some specific material on this. So moderate level of exercise at the edge of conversational, where you can maybe exclusively breathe through your nose, right? So this is like taking a stair stepper or a treadmill with some incline and trying to go at a pace where you're consistently at that level of exertion. And then really resistance training has this very special way of really reversing this. So not only does it burn energy, it actually brings a new type of receptor to that muscle cell, and it allows muscle cells to be able to not only take up more blood sugar, but actually store more blood sugar. And so that's one of the adaptive changes to resistance training. So it sort of has this independent pathway of energy output that really seems to allow us to reverse this insulin resistance. So again, I would say, so that looks like can be calisthenics, again, push-ups, wall sits, other things that really don't require a weight room, air squats, other things like that. And then as you're maybe getting really, and yes, it may require looking at exercise bands or adding weights and things like that to continue maybe moving forward in that. But again, I think people of all levels can start somewhere. The point is not that you lift 100 pounds, it's just that you lift something that is causing your muscles to, put a little bit of strain on them and have this resistance type response. So again, other aspects of our life, so sleep, again, very important aspects. So sleep is an extremely complicated topic. I would say many of these things we could focus an entire talk on. Sleep, definitely, we could spend an entire hour or more talking about. So again, but just realizing that sleep is involved here and that we need to prioritize that, find why we're not sleeping, try to address those things. And maybe it's one of these things like chronic stress, psychological stress, and inflammation. So this, is again, things like if you have autoimmune disease or, whether that's sort of physical or mental stresses that are kind of chronic like that and stressing the body, right? That also interferes with the way that insulin signals and may even raise blood sugar through things like elevated cortisol chronically. So that's how this is sort of involved there. Just a couple practical things here as far as, what does this look like as far as, okay, you said avoid the breads and the pastas and potatoes and etc. So what do I eat? So hopefully this is kind of just gets you guys started on some things. So for chips, we're looking at if you do eat dairy or other cheese products, then cheese wisps there. So these can be found at most grocery stores. Bean pastas are becoming much more available. These are, chickpea, black bean, red lentil. Again, there is some difference in texture and taste, but I do believe that, again, we can all kind of adapt to that, especially if it's, our long-term health, right? Is that worth, eating pasta that tastes just slightly different? I personally think so, but again, that's a personal choice. So spaghetti squash, instead of our regular pasta, rice cauliflower instead of rice. Again, we have a lot of options as far as high fiber tortillas, maybe thinking about veggies kind of in dips instead of chips, even with salsa or whatever other kinds of dips. Again, keto desserts, again, I just want to reiterate that some of these things definitely are not low calorie products, right? Especially our kind of keto dessert protein ice cream shakes. So more and more people getting really creative with these recipes and finding ways to really make tasty things that are have much better nutrition. But again, we just want to remember that if that's your 4,000 calorie of the day with this protein ice cream shake, then it's very hard to maybe reverse insulin resistance. Even if all of your calories are from mostly fat, we may still have some insulin resistance there. So we still have to reduce calories a lot of times to maybe get this reversed. But again, as far as compared to maybe some traditional products, and with that calorie caveat, I would say these are some better options. So what else as far as kind of exogenous compounds? Um, so we have a lot of different drugs here in this category. This is not by any means an exhaustive list. And, that those both are sort of natural compounds all the way up to prescription drugs is what I'm talking about here. So again, this is for what I know, am aware that has actual scientific evidence behind it. So all of these things actually have some, scientific studies that were done on these actual materials, as well as, again, practical use that we've seen in the world. So lemon, so it looks like about at least half a lemon to a whole lemon squeezed into a cup of water actually can buffer some glucose response to foods. Cinnamon, both kind of extracts as well as even, like a teaspoon to a tablespoon, or probably about a teaspoon, cinnamon starts to have effects. I mean, that's, again, a lot to sort of take at once. So a lot of people take this in capsuled form. So there are some others out there. Again, I haven't done, exhaustive research sort of in that particular arena. I'm sure that there are a few other, plant-based compounds or other things that are on that list. Berberine is certainly one of them. It's very similar to the action of metformin, so I actually put the prescription drug there next to it. Berberine, I believe, is golden seal extract, and has very similar action to metformin, which actually is derived from French lilac. So again, just to reiterate that many of our prescription drugs have sort of quote unquote natural origins, and we wouldn't want to necessarily take them in their natural forms because they're much less potent or have many more side effects, etc. Okay, and then as well as probiotics actually have evidence. So prebiotics, I'm not aware of scientific evidence, but probiotics, there is specifically some formulations of probiotics have been shown to lower A1C, lower glucose response to certain, to foods, etc. And then kind of our most popular category of at least prescription drugs these days that are more well-known are sort of these GLP-1 agonists, peptides, semaglutide, tirzepatide, so that's Ozempic, Mounjaro. There's many other drugs in this category, some older drugs that actually work on GLP-1. Some of our probiotics may be working through this GLP-1 pathway. So a lot of interesting things happening in sort of the molecule world as far as this goes, and trying to have maybe more useful molecules and specific kind of compounds for people to use. So again, I just want to pause to say that I certainly realize that I'm sort of talking about this in a matter-of-fact way, but it's not necessarily that easy to make a lot of these changes. That many of our eating behaviors are not just, hey, I'm just gonna buy this food and eat this food, and that's it. And again, it's interconnected with our social lives, with again, maybe past traumas, with all sorts of aspects of our lives. And it's just this multifactorial, again, interconnected, right, thing. And we're not really set up for success here. I really don't think, the food environments and what sort of advertisement, etc., and other just what's around you in a lot of areas of America, I think really drive us to overeat and to, again, it's encouraged in some ways. We feel guilty if we don't finish our plate. Again, so many layers of this. That are sort of part of our culture or part of our family environments. Again, different cultures sort of have different aspects of this as well. And then sort of, again, that fast food environment, cheap food environment here in America, I think really drives us to some of the foods that might encourage overeating and encourage insulin resistance. So just acknowledging that, again, it's not really everyone's fault, right? We're all in this world together, so we all just need to do the part that we can. And again, I don't necessarily blame any one kind of entity or anything like that. I think, we're sort of these ancient bodies, and we've, again, the world is just adapting and changing so quickly. And again, our bodies don't adapt and our minds don't adapt that quickly. And I think it's just that contrast that really creates some of that But I do think that's not an excuse to not take some ownership. If you know this is going on, that's what I think my role is just telling people, hey, this is happening, right? So that we can all kind of take ownership of it in our own ways and go on our own journeys to finding a way to fix this if this is something in your life, and or even just finding out, right, if this is something in your life. Um, Again, so thinking about it, how can we make this a lifelong change, not necessarily have just those, we're going to do this particular diet, or I'm going to do this 5-day fast, which again, many of you know that, I may even offer here. So, but that's, again, that's not something we're going to do long, maybe long term, or maybe it is, right? But just thinking about, is that a part of your long-term plan? Where does that fit into a lifelong of really having to maybe battle this or be aware of it, or really be, assess it at least, right? So thinking about sustainable ways to reverse it if you do have it. And then again, just taking some of that off of that you morality kind of sense here. The brain's reward system, and we have these kind of neuropod cells in our gut that detect glucose and fatty acids, and they put dopamine directly into the brain, into these reward systems. And many of us think, again, I like cake, or I like pizza, or I like ice cream, or French fries, or some of these bliss foods have those characteristics from a very nutrient sense. And what we see is, again, that is a huge dopamine signal, and that some of that is just biochemistry. And dopamine is the brain chemical of drive, motivation, craving, pleasure, many things like that you use the words that you could use to describe dopamine. So again, just, is that really your preference? Sure, maybe, but otherwise I would say there's a huge biological drive there too. So maybe it's not your preference, and maybe that food is really controlling us, right? And again, we just have to take that ownership and say, no, I'm not going to let this sort of innate signal. I mean, if you think about it from an evolutionary perspective, you haven't eaten, or you've eaten very little, hunter-gatherer tribe looking for food, you find, again, something that's very nutrient rich, right? It would very much serve early humans to have signals to consume as much of that as they can, push as much of that into fat as they can, right? Because again, maybe all winter they don't get another big bounty like that. And so if you think about it from that perspective, I think it makes some sense why our brain's set up this way. It's not set up to make us fail and make us fat. And, again, the modern world just has a plethora of food options that are very tasty, that are easily digestible, and that is not the environment that our sort of brain and bodies were really used to. And so we have to kind of go back to those drives and realize, do we want to listen to them or not, right? I think that's the beauty of being a human being, that we actually get to kind of choose that. So again, just being patient with yourself and having some consistency, making a plan and really sticking to it for a couple weeks. These things take time. They're really deep habits. So giving yourself at least, 3-4 weeks of sustained change before you really tell yourself, hey, this isn't working. Right? I think that's another thing I see a lot of folks taking 1 week, maybe even 2, and really feeling like, hey, that didn't work. Some of the gut changes, some of the brain changes probably take longer than that, and maybe up to 3 months, right? So we really want to be patient here and consistent with some of our changes. So what are some key takeaways from this talk? What are kind of some of the top things I would like you to walk away here with? Really, honestly, just be curious and obtain information, right? So I think this is a very complicated topic. I'm not here to tell you I know every single detail on this. And I would love to, hear anything that anyone else has to say, on this, or, if people want to present certain things and share, evidence or other useful things in their lives, right? That's certainly what I'm trying to encourage. Again, make this personal, right? So what are your personal goals and objectives, right? So if this leads, usually fixing this does lead to some weight loss. If we're talking about some resistance training, other things like that, then you increase some functionality, maybe you look better, right? But maybe there's totally other goals, right? I want to be around for, whatever, I want to be a healthy 70, 80-year-old, right? That's what I talk about in sort of our longevity and health span talk, right? I don't want to be laid up in bed when I'm, or I don't want to take diabetes medicine when I'm older. My family, everyone takes diabetes medicine, right? So how can we prevent that? Well, we can find resistance and really make it personal and have good reasons for you to be motivated to do some of these things. It's a lifelong journey, right? So this is not just I do one thing for 6 months and then I'm good, right? You really want to think about these lifelong learning adjustments and changes throughout your life. Responding to data, again, that's one thing that I really encourage, especially my patients here in the DPC. Let's get those insulin levels. Let's get them a couple times a year, and do some of this testing and really look at this stuff and make some really dedicated changes and then see if that really helps you. And then, once we know that that's working, maybe again, you can loosen up a little bit and, still sort of be, that 80-20 rule or 90-10 rule. If you're doing right, again, 80 to 90% of the time, you're really going to be okay. Again, I think I've really stressed how enormous the scope of this problem is and how important starting early is and using multiple approaches. And then again, I think just acknowledging that there are a lot of emotions around this, eating behavior and food and nutrition and even attitudes around exercise, or again, maybe this is all emotional and this is, from past trauma that's wrapped up into this and that's really causing some of this stuff. And so again, just trying to find a way to let those emotions be the passenger in that car and to not let them drive you, right? So whatever that takes, whether that's going and taking a walk all the way through years of psychotherapy that many folks may require. Again, all of us just have that personal journey and want to acknowledge those emotions and find a way to take back that driver's seat. So these are some of my top resources here for this talk and just some good resources for patients. Levels Health has a lot of good information on recipes and other kind of specific things there. Not their blog specifically. Peter Attia, as many of you know, is a certainly an inspiration to me and has much more thorough and excellent information on his website on this topic. Again, there are huge medical institutions that put out a lot of things on this topic as well. Again, so there's a lot of information out there, and it's really just a matter of taking ownership and really investing that time and investing in yourself ultimately is really what we're talking about here. So thank you everyone who's there signed on online and watching online. We will have another meeting and in person, online, everything kind of meeting here on July 12th. We'll try to be on time that time. And thank you again for everyone who's watching this online. And please comment if you'd like or contact me directly. Thank you.